Good evening to you all. It's indeed wonderful to have you all back here to have the ophthalmology PG classroom. Week after week, we have been doing. 1 week we are doing a case, and the other week we are doing investigation. And this time, with us, postgraduates from Little Flower Eye Hospital, and they will be presenting a cornea case, a corneal edema, and it will be discussed by Dr. Thomas Kuriakos, former professor and HOD of Christian Medical College, Vellore, currently working in Giridhar Eye Institute. Welcome to you, sir. And from Little Flower, we have host faculty in the form of Dr. David Pudukadan, as well as Dr. Hilda Nixon, and Risha, their postgraduate coordinator. Let's, without wasting any time, Rehna, are you here? Okay, let's start the program. Let's start the presentation. Can we have the case presented now?
Yes, sir.
Let's hope that we have a very fruitful 1 hour of discussion.
Hello.
Yeah, you are audible. Your case is seen. Can you go to the next slide? Very good.
Sir, shall I start?
Sure.
Yes, please.
Good evening, all. A 74-years-old female coming from Chennai came with the complaints of defective vision of both eyes for the past 6 months, and also difficulty to look at the bright light for 6 months of duration, and halos for 4 months. History of presenting illness. History of defective vision in both eyes, which was painless, gradually in onset, slowly progressive for the past 6 months. She also noticed that the blurring was more during the morning hours after waking up from sleep. There was also history of glare during the past 6 months and history of halos in the last 4 months. No history of watering, photophobia, or redness. No history of floaters, flashes of light. No history of any ocular trauma. No history of headache or bloating. No history of vomiting. Past ocular history. She is using glasses in the last 10 years. No history of any similar complaints in the past. No history of any ocular surgeries in the past. Medical history. She is not a known case of diabetes or hypertensive or cardiac patient. No history of any stroke or kidney disease or dyslipidemia. Family history. There is no history of similar complaints among the other family members. Coming to personal history. Sleep and appetite was normal. Bowel and bladder habits also was normal. She takes a mixed diet. There were no addictions. General examination. The patient was conscious, oriented, moderately built and nourished. No pallor, icterus, cyanosis, clubbing, or generalized lymphadenopathy was there. Pulse rate was 76 per minute, regular in rhythm and volume. Blood pressure was 120/90 millimeters of mercury. Respiratory rate was 22 per minute. Systemic examination. Cardiovascular, respiratory, gastrointestinal, and nervous system was within normal limits. Ocular examination. She had a normal head posture. Ocular posture, it was orthotropic. Corneal reflex was central. Extraocular movements was full and free in all gazes. Refraction and IOP. Refraction in the right eye. Her unaided visual acuity was 636. There was no improvement with pinhole. And on undilated retinoscopy, the reflex was dull. Subjective refraction showed no improvement, and it was 6/36. With near vision, with +3 diopter spherical lenses, her near vision was N36, and intraocular pressure measured with Goldman's applanation tonometry at 9:30 a.m. was 15 millimeters of mercury. Refraction of the left eye, her unaided visual acuity was 6/24. With pinhole, it improved to 6/12. Retinoscopy undilated was done, and on subjective refraction, her vision improved to 6/12 with -0.5 diopter spherical and -1.5 diopter cylinder at 75-degree axis. Her near vision with +3 diopter spherical was N6, and intraocular pressure using Goldman applanation tonometry at 9:30 a.m. was 12 millimeters of mercury. Anterior segmental examination of the right eye. Lids and echinacea, lid margins were healthy, eyelashes was normal, rhotas was negative, conjunctiva was normal, Cornea was normal in size and shape. Epithelium showed few microbullae. There was a localized area of stromal edema, 5 into 4 millimeter size, involving the central and infratemporal area of the cornea. Endothelium showed diffuse guttae. There were no keratic spitates. Corneal luster was lost. The corneal sensation was same in all quadrants. Anterior chamber was normal in depth, Van Herrick's grade 3. There were no cells or flakes. Iris was normal in color and pattern. It was 3 millimeter in size. It was round, regular, and reacting to light. Both direct and consensual light reflex was present. Lens showed nuclear sclerosis of grade 3. Anterior vitreous space was white. Fundus examination of the right eye with distant direct ophthalmoscope, it showed a dull glow. With slit lamp examination using 90 diopter lens, the media was hazy and posterior fold details could not be made. Confirmed with an indirect ophthalmoscope using 20-day lens. Coming to anterior
what happened?
I think she lost her connection.
What happened suddenly?
I think
Dr. Sterin, can you hear me?
No.
It's a network problem. Her screen has stopped sharing.
Okay, sir. So based on the history so far, probably you can have a discussion with the other postgraduates by the time she will come back.
I don't see anybody on the who are the postgraduates on the only one person or who are the postgraduates? Okay, what's the main history? What's the presenting complaint? What's the main thing that strikes you? Anybody? I don't know who is there. Sorry.
David and Anusha, you can help us. Who are the postgraduates?
Dr. Arunlal, Dr. Nini George, Dr. Chelsea.
Okay, there. I don't. Okay. Yeah, sure. Okay, I can. Okay, maybe I'll just take somebody from random and okay, Nimmi George. Can I ask you what is the main sort of presenting complaint this patient had?
So patient had blurring of vision, which was more in the morning.
Morning, yeah. Why did the patient complain? Why did the patient say it's more in the morning? Any particular reason you can think of? Why did it? Why should it be in the morning?
The patient is sleeping due to reduced blink rate. The corneal surface will get dried up.
Oh, during sleep, the cornea gets dried up. Is that what you're saying? Huh?
There will be no evaporation, so the edema will increase in the morning. So that is very much.
Evaporation. What do you mean by evaporation? What evaporation means? What do you mean? I didn't.
Since eyelids are closed.
Ah.
Eyelids are closed, so the edema will.
Okay, so the water that collects doesn't get out.
Retention.
Okay, sure. That is one reason that the evaporative loss from the cornea is not there during the night. What else? What else happens?
Endothelial are highly metabolic nature. They are actually aerobic metabolism.
Yeah. Okay, Sarin, you must have read up. I was just, I thought like the.
Okay, sir. Okay. Sorry.
Nimmi.
Try answering. In case in case known as hamstrings, Dr. Sterin can help.
Yeah, sure. Nimmi George, what is your other reason for? What are the other reasons why the problem is early in the morning? Huh?
Sir. No, sir.
Okay. Okay, Sarin, you can continue then. Yeah, tell me what is the other reason?
Sir, endothelial cells are highly metabolic. So,
Yes, you want to add?
and they actually, hello? Hello?
Yes, we can hear you.
So they undergo, during the night when the lids are closed, they have no exposure to the oxygen. So there is anaerobic metabolism that takes place, and there is accumulation of lactic acid derivatives.
Okay.
And also,
So that's the
when
other thing.
eyelids
So
are
you
closed-
have a low oxygen concentration at night. Yeah. So where do cornea get any oxygen at all at night? Where do the cornea's oxygen come at night at all, or they are totally starved? Does any oxygen reach the cornea at all at night?
No.
It's supposed to diffuse from the underside of the blood vessels of the lid. Okay, they're supposed to give what little it gets. It's supposed to come from there. Yeah. Okay. What else causes decreased vision in the early in the morning? You
Edema.
said so that causes edema. So all these two causes are edema related. Yeah. Anything else? Anything else? So what does the edema itself do to the corneal curvature?
Increase in the corneal curvature.
Yeah, so that depends. So yeah, so the corneal curvature usually can increase actually. Okay. So the corneal curvature increases, and then that can cause a refractive related change also. A decrease in vision due to a refractive change, whichever way it goes. So that's the other reason early morning there's a decreased vision. Then the patient is also complaining of glare. You said glare.
Yes, sir.
Why do you have glare?
Glare is actually intolerance to the bright light. Again,
okay, so if you're telling it is intolerance to white light, you've also said there is no history of photophobia. In your history,
photophobia is actually intolerance to the ambient light.
And glare is what? Extra light, is it? And who decides what is extra and ambient? That is really cutting, I think, splitting hairs there. Light in any form, either you can tolerate, and what is a cutoff decibels or some, difficult to say that. So, if there is, yeah, so why do you have glare? That actually a lot of these patients complain of not photophobia in the, so they are unhappy with excess light. And what's the reason for the photophobia?
Corneal edema.
Well, why should that cause glare?
There is scatter of light.
Yeah, scattering of light is what causes that. Okay, fine. Yeah, so you are okay. You can continue your presentation here. Yeah.
Coming to examination of the left eye, anterior segment examination of left eye. Lids and diaphragm, lid margins are healthy, eyelashes normal, rhoplast was negative, conjunctiva was normal, cornea was normal in size and shape, epithelium appears normal. The endothelium shows diffuse butte, and there were no keratic crustates. Corneal luster was normal. Sensation was present in all the quadrants. Anterior chamber was normal in depth, Van Helix grade 3. There were no cells or flare. Iris was normal in color.
Okay, now you are saying, okay, let me just, one sec, let me just stop you here. So there are two things I just need to go back on presentation. You presented the systemic, all these CS and all these various systems. Is it because that is still a routine what people examiners expect, or you think it's also related to the case? Why did you mention systemic examination? Is it because examiners expect, or is it got something to do with what you're going to make a diagnosis on, or anything else? Why did you go through the systems in your presentation?
So in conditions like granulomatous uveitis, systemic involvement is there.
Okay. So, yeah, so what systemic involvement did you expect to pick up in the examination you just mentioned? You know, which, like in the heart, what do you expect in a granulomatous uveitis, which you could have picked up from your general examination? No, what I'm trying to say is, one, you don't really have time to, I don't know if examiners expect it is a different issue, but I will definitely not expect it. But first thing is you don't have time to do all these examinations at all in 30 minutes that you have, isn't it? All that systemic examination you mentioned, do you think it's really possible to do justice to that? What do you think? Sarin, what do you think? Hello? Have I lost? I think she's lost.
Maybe they can do a evaluation of the associated, if there is any systemic association expected. Specific things can be evaluated rather than doing the whole systemic. Yes.
Absolutely. And just going through that without any, just a broad brush like that may not be a good idea, I think. Yeah, like if it is specifically related to the case, going to help in some way, you can do it. Otherwise, probably just going through the entire system may not be a good idea, I think. And yeah, sure. Then, okay. So is Sarin there on the online, or has she gone off? Is she lost? Okay. So let's see. Is Dr. Chelsea one of the postgraduates? Yeah. Okay. So Chelsea, when what are the other corneal findings they mentioned? What are the corneal findings she mentioned?
Sir, epithelial edema.
Okay. Now you said epithelial edema, she said. How do you figure out epithelial? How do you examine for epithelial edema, or how do you look for epithelial edema?
Sir, on slit lamp, when we keep an optical section, we can see whether it is a microcystic or any macrocystic.
So on slit lamp, you can make out the macrocystic in the microcystic thing on just looking at the slit, is it? Is that the way you look for microcystic edema? Have you seen microcystic edema on slit lamp examination? Yeah? Chelsea, have you actually seen a patient microcystic?
Yes.
You have?
Yes.
What's the best way to make out microcystic corneal edema? What examination, slit lamp examination strategies do you know other than direct,
Retroillumination.
Retroillumination, what else?
Yes.
Retroillumination, then what else?
High magnification.
High magnification, that's...
Paralapoid.
Sorry? Well, other than retroillumination, what else? What other strategies do you know? Have you heard of sclerotic scatter?
Yes.
What is that? In fact, so there what you do is you shine the light to the limbus and look for light which gets reflected in the stroma. And the pattern you get, if it's clear, then if it's not clear, you get these, in the background you get these microcysts. Even retroillumination is a reasonably good method for looking at microcystic edema. Okay, a direct examination to me is not a great way to make out a microcystic edema, I think. The big bulla, yes, you can actually see through a slit, but not microcystic edema. Microcystic edema is all best seen off-center examination by sclerotic scatter or retroillumination. Okay, what else? So the findings, one was microcystic edema. What else? What are the other findings?
Stromal edema.
Stromal edema. What about stromal edema?
So you will see the increase in the stromal thickness.
Okay. Did anything specific about the stromal edema she was presenting? There, Sharon is back. Anything specific about the stromal edema? What did she present? Anything? Was it, okay, let me give you a hint. Was it a diffuse stromal edema or something else? Sharon, you want to put that picture up, which you presented so that you can, not that, actually that picture may not be very helpful for the other, your drawing may be a little more useful for them to recollect what, okay, now what do you see here?
So localized stromal.
Sorry?
Localized only, not diffuse.
It is organized? Sorry, I didn't get you. It's localized.
Localized, localized.
Yeah, it is localized. It's
not
a localized
diffuse edema.
Yeah, so that you cannot say whether there's a diffuse edema, there is no diffuse edema, but there is definitely another area of localized edema. At least that's what she has drawn. Yeah. So why would you get localized edema like this? If you get localized edema like this, what would you suspect? What would you suspect if you get localized edema like this? See, this patient is not post-operative. This is it's a sort of insidious onset, isn't it? Yeah, and then they come with localized edema. Sarin, what would you suspect if you see due to what?
Viral endothelial.
Yeah. So you may, you sometimes wonder if you have such localized this thing, if the patient has had no surgery in the past, one would wonder why there is a localized edema like this. Did you consider viral in this patient's diagnosis?
Yes, sir.
Yes, you did.
Yes, sir.
So what did you look for to sort of rule in or rule out a viral involvement?
Sir, the edema was localized, but endothelium showed gutty, and there were no keratic precipitates in this patient.
So there was no keratic precipitates in the bone. So, okay.
So what about AC reaction?
AC was white. There were no cells of flare.
So again, AC reaction in the presence of a corneal edema. How good is it? Do you get, I mean, when you have corneal edema, or diffuse corneal edema, or diffuse epithelial edema, like you said, this patient had, is it really realistically possible to see anterior chamber cells and flare very well? In fact, you said there is nothing there. Yeah? And my contention would be because of the edema, you did not see it. Okay, I would even sort of argue that, well, your slit lamp light is not good enough to see cells and flare, especially in situations like this. So not seeing that may not be, may not be that it is not there. Yeah. So I would be a little worried when I see localized edema. How common is, in a pristine, untouched, surgically untouched eye, how common is localized edema like this? Okay, so that would be my worry about that. But so, like, coming back, what would you look for to sort of, either aid you or reject that hypothesis of viral etiology?
So she does not have any pain.
Sensation is one thing, but okay, sensation is one possibility. What else?
Recurrent episodes.
Sorry?
Past history.
Recurrent episodes. But how would,
I would
so how would you look
request,
for how would you sort of figure out if it's a recurrent episode?
PGs kindly switch on your video, so it will be more interactive section. When sir is asking questions, no? So whoever is answering, please switch on your video too.
No, they don't have to put on video. Then they're scared that may they can sort of. I don't mind you without the video also talking. Huh? So yes, recurrent episodes. What will you look for in recurrent? I mean, like, how would you figure this out? Recurrent episodes.
Recurrent episodes, there will be scarring.
Okay, yes. So first is history, whether you have had any similar issues like this ever in the past. Okay, that's the first thing. And then scarring. So when you present, I would expect you, if your DD is, one of the DDs is, which it should be, is viral keratitis, you should then say, I looked for a scar and it was not there. Okay, so basically you're telling, if it is for the exam purpose, you're telling, look, you're telling what you're conveying to the examiners, look, I know that, this is one of my DDs. I have made taken extra efforts to rule it out or rule it in, whatever you may want to. Okay. And so that's the message you want to give. So while your presentation, you should even look in the other eye to look for any scars. Okay. Okay. Then, yeah. So, what is the intraocular pressure?
It's 15 in the right eye, 15 millimeters of mercury in the right eye.
Right eye, yeah.
12 in the left eye.
Why? So, I could even contend that, so let's say viral keratouveitis, pressures go up or pressures go down? Oh,
go up.
Go up. Why? Generally in uveitis, what happens?
There's an inflammation. There will be cells that plug the trabecular meshwork.
Yeah, okay. And cells that plug the trabecular meshwork and?
There's an impaired aqueous outflow. There can be a rise in intraocular.
So you're saying in uveitis, generally the intraocular pressure goes up? Yes or no?
Yes.
Yes. Any PGs disagree with that? Uveitis, Sarin claims uveitis, the intraocular pressure goes up. Anybody thinks otherwise?
No.
Huh?
Can be low also.
It can be low also. Or is that the general rule that it is low?
It is ciliary shutdown.
Okay, no, first tell me as a general rule, uveitis, is intraocular pressures low or high? In plain uveitis, huh?
High.
No. Generally, in uveitis, the intraocular pressure is low. Anybody the reason for that? What are the ways gets out of the eye? What are the ways aqueous gets out of the eye? How does Paul, how does the aqueous get out of the eye?
The trabecular outflow and uveoscleral outflow.
Correct. In uveitis, the uveoscleral outflow is enhanced. Okay. And also, there may be, like she said, if there's bad uveitis, there can be a ciliary pull and things like that. And the production can be less. But the primary reason yet intraocular pressure is low in uveitis is because of the increased uveoscleral outflow. Okay. There is one uveitis which actually causes raised in pressures, and that is actually the viral keratouveitis. Okay. Sharon, and here, why do you have raised intraocular pressure in viral keratouveitis?
Sir, in viral keratouveitis, there will be inflammatory cells and the pigments.
See, inflammatory cells and this thing takes time. See, viral keratouveitis, if you develop viral keratouveitis today, tomorrow the intraocular pressure will be high.
The trabeculitis.
Correct. Good. trabeculitis. Along with the keratitis, you get a trabeculitis and there is trabecular edema. Okay, so that's what causes this higher intraocular pressure. And in this, coming back to this case, when you see a 15 compared to a 13 in the other eye, I would again be worried whether is there a, I'm not saying there may not be a guttate. I am just wondering, along with the guttate, on the background of a guttate, are we looking at a viral keratitis? Okay. Sarin, you have drawn a Decimet's folds also here in this localized area.
Yes.
Why do you get Decimet's folds?
Sir, when there is localized edema.
Localized edema, what happens?
Sir, it's actually the posterior part of the posterior beam that actually has more holds more water.
It's not that it holds more water. Why should only the posterior part hold more water? That's not really the reason. It's okay. Let's say it holds water. Then why should it fold? Why should it fold? Because as it moves, due to
endothelial pump failure.
I know, true, but why should you have the folds? Why would you have Decimet's folds there? That's because the surface area, the inner surface area. See, in a biconvex, in a concave or whatever way you want to look at the surface, has a certain area, okay? And when it swells up and starts becoming flat, the surface area reduces. Do you get what I'm trying to say? No, or have you lost me? So that surface area reduces, and to accommodate that reduced surface area, that they'll have to go into folds. A larger surface area, when you make it a smaller surface area, the remaining thing has to fold up. You understand?
Yes.
Yeah?
Yes.
Yeah, so that is the reason you get those folds. And the reason it's not because water collects more in the posterior part. It's only the posterior layers are more amenable to the change of shape. The anterior curvature is much more fixed or a little more stable and difficult to change shape. So that's why the posterior one moves backwards. Okay. Okay. Continue with your presentation.
So anterior segment of the left eye. Lids and techniques lid margins were healthy, lashes was normal, pupillus was negative, conjunctiva was normal, cornea normal in size and shape, epithelium appears normal, endothelium showed diffuse guttate. There were no keratic precipitates, corneal luster was normal, corneal sensation was present and seen in all the 5 quadrants. Anterior chamber was normal in depth, Van Herrick's grade 3, no cells or flare. Iris normal in color and pattern. Pupil was 3 mm in size, round, regular, and reacting to light. Both direct and concentric light reflex was present. Lens showing fluorosis of grade 2. Anterior face was quiet.
See, okay, fine. In both you have said anterior vitreous phase is quiet. It is very difficult to make out with corneal edema. It is not very difficult to make out anterior vitreous phase and all, I don't know. I find it very difficult. If you have seen it, well and good. But I would be very surprised if anybody could make that out. Okay, continue.
Fundus examination of the left eye. With distant direct ophthalmoscope, red glow was present. With SITAM examination using 90 diopter lens, the media was clear. This was normal in shape and size, with distinct borders, and a published ratio of 0.5 with pink and healthy neuroretinal rim. Vessels arising from the disc branching dichotomy.
No, this is the left eye, isn't it?
Yes, sir.
So, see, right eye, you really couldn't even make out much of the fundus details. Yeah?
Yes.
And you said, and you claim that the anterior vitreous phase is all right. Okay. No, what I'm trying to say is, I can tell away straight away that you've not even looked at the anterior vitreous phase. And I'm sure you've not seen the anterior vitreous phase. Okay, because it's not possible. But anyway, so, people could catch you out on those. So don't present things you have not even looked at and hope that, you may get away with it. If you have not seen, don't even mention it and get into trouble. Okay? Okay.
Vessels arising from the disc branching dichotomically and maintaining an AV ratio of 2:3. Foveal reflex was dull, and with an indirect ophthalmos using 20 diopter lens, the above findings were confirmed, and periphery shows a tessellated background. Fundus of the right eye, fundus of the left eye. Summary: 74-year-old female who had a defective vision in both eyes for 6 months duration, and also glare and halos. Her best corrected visual acuity was 636 with N36 in the right eye and 618 with near vision N6 in the left eye. Anterior segment of the right eye, the cornea showed corneal epithelium showed fibulae, and there was a localized foveal edema of 5 to 4 central and in the infratemporal area. And the endothelium showed multiple ducting. Fundus of the right eye was AV. Anterior segment of the left eye, the cornea endothelium showed multiple ducting, and the fundus examination was normal. Provisional diagnosis: right eye, Hughes endothelial dystrophy, stage 3. Left eye, Hughes endothelial dystrophy, stage 1. Both eyes senile immature cataract. Left eye, compound myopic astigmatism.
So what do you mean by endothelial dystrophy stage 1, 2, and 3? What are the stages?
So clinically, there are 4 stages. Stage 1 is where there are diffuse guttae, and stage 2 is where there is guttae and there is mild distortion of the architecture. And stage 3
distortion of architecture means
endothelial hexagonal shape of the cells, architecture of the endothelial layer.
Okay.
And stage 3 there will be
no. So stage 1 is what? Can you just tell me once again? Stage 1.
Guttae.
Okay.
Stage 2 is guttae with loss of the normal architecture and edema. Stage 3 is guttae with loss of architecture, edema, and bulla. And stage 4 is scarring.
Okay. Now you called it stage 3, edema and loss of architecture. Now, is this diagnosis clinical or with doing a specular microscopy?
So this is a clinical diagnosis.
But you said loss of architecture, cell architecture. How did you make
We
that
have
up?
done a specular.
You did a specular. So this provisional diagnosis, is it a clinical diagnosis or a final diagnosis after all the investigation? Or is specular part of your clinical examination, routine clinical examination? Do you get what I'm trying to say?
This is a provisional diagnosis. She has bulla.
No. Provisional diagnosis based on, what I'm trying to say is, if you're bringing in corneal cell architecture based on endothelial study, how can that be a clinical diagnosis? Do you get what I'm coming to? Huh? Okay, continue.
The following are my differential diagnoses: corneal endothelial dystrophy, posterior polymorphous corneal dystrophy, corneal hereditary endothelial dystrophy, eye syndrome, herpetic vesiform keratitis.
Okay. Now, okay. So I would really go to the. So can I ask you something? I would have actually. Did you take the history or did you take this? Was she presented off the charts? Partly, at least.
Sir?
So did you take the history yourself for this patient?
The charts.
From the chart. Why I'm asking that is, was there some precipitating factor that brought her in? That's my worry. Is it a 6 month? Sure, she may be having a 6 month early morning mild blur. I'm not saying no. But my worry is the immediate reason for her to come, was there an acute loss? I would ask that question to that patient again. I mean, I would, because, for me, with your presentation, a viral keratitis on the background of a fix is still quite high. And my reason for that would be localized corneal edema. Of the two, the pressure is high in this eye, all those things. Okay, normally, yeah. So tell me normally corneal edema related intraocular pressure measurement, what happens?
Sir, in corneal edema, the thickness actually increases, but the intraocular pressure is actually underestimated.
Correct, absolutely. So the intraocular pressure, this 15, which is already higher than the left eye, is an underestimation. You get what I'm trying to say?
Okay.
So the real one may even be higher. So that would be my worry, that this is actually probably in the background of a, so, and I wouldn't keep my viral diagnosis so low down. If you want to put Fuchs first, no problem. Okay, but again, I would ask you, why are you putting Fuchs the first diagnosis?
Because it is bilateral and there are guttae in both eyes.
So presence of guttae itself doesn't, how common is guttae in the population?
In the old age population, just
yeah,
common.
This patient is 70 plus, no?
Okay.
So how common is guttae in the population? Huh? Any idea? I'm not quite sure of it myself, what is the exact, but it's definitely, to my knowledge, it is after 70, guttae is, the seeing guttae changes is quite, probably even more than 20% probably. But if anybody knows the number, I'm quite happy to accept that number. Okay, so just seeing guttae. So tell me, how did you make out the guttae, by the way?
Sir, with specular reflection.
Specular reflection, what did you do? How did you do this specular reflection?
Sir, it's based on the Snell's law, where the angle of incidence is equal to the angle of reflection. The microscope and the illumination system is at an angle of 45 to 60 degrees.
Okay.
And where you get the corneal reflex adjacent to it.
Where do you, sorry, where do you?
The corneal reflex, where you get the corneal
reflex
adjacent to it in a high magnification with full slit height.
No. So where you get a corneal reflex, you go and look there, is it? Sir? Is that what you do?
Adjacent to the reflection.
No. You mean the Purkinje one image, yeah? Is that where you're saying?
Yes, sir.
You look close to that. Yeah? Is that what you did?
Where do you get the Purkinje one image from?
Anterior corneal surface.
Okay. So you just go next to that and look there. And what should be your slit measurement, size, or it can be the, you make it completely open and do it, or completely, what should be a light size or shape or whatever?
So thin slit, maximum height.
Thin slit, thinnest possible slit.
No, not the thinnest possible slit.
Maximum height. And maximum height, is it? Did you actually see this, or you just looked at did you see this patient, or you just looked at the specular only?
No, she's on follow-up with us.
Okay, she's on follow-up, all right, but did you actually do this, this reflection technique on this patient? And then what do you see with you keep your, and then, and any other change you will do to the slit lamp? Anything else special you will do to get this reflection? Okay, let me ask you, is it you keep both eyes open, both eyes closed? I mean, you can't do it with both eyes closed. One eye open, or how do you do this?
One eye closed.
And then, why do you do it one eye closed? Huh? You've not really looked at it. It's a good technique for you to learn. You know, you should go and read the actual technique. First, do it on normal people. So what you really should do is very roughly is, after keeping these, size, the light under this thing around 45 to 60 degrees, once you see the reflex, the corneal reflex, you have to superimpose the light onto that corneal reflex. You understand? And your light actually should be a very small, some people use just a 2.2 millimeter or a slightly bigger, or even 1 millimeter round this thing. Or you can make it also a slit. It cannot be too big. Okay. And ideally, if you're using a Hagstride slit lamp, you have to put the 10x magnification, and it's a uniocular thing. You will only get this reflection in one eye. You don't get it in both eyes. Okay, and you have to put the higher magnification, and then the other magnification also increase. You have to go to the highest magnification to really see this. Okay, it is a technique people should read and sort of, do it yourself. It's a good technique. Actually, it's not very difficult to do at all, provided the slit lamp is good. If the slit lamp is not good, you will not get the specular very well. Okay. Now you can put your hand to your heart and say, did you really do it, or you just sort of, have you ever seen these slits? Huh?
I've seen specular.
You've seen, no, the slit lamp specular reflections,
Yeah.
have you seen the cells? Yeah, you have. Okay, then well and good. Okay, so, but this is the correct technique of doing it. Okay. Okay, coming to specular microscopy. Yeah, what about it now? Investigations, did you do a specular for this patient at all?
Yes, sir.
Have you got the pictures? Huh?
So this is specular of the right eye.
Well, this is not a great specular, isn't it? They got a size and all that, huh?
But thickness showing 0.58 millimeters, and number of cells was 3.
0.58 is not even very thick. It's not even too thick, isn't it? Yeah.
Yes, sir.
Usually you don't get much edema at 584, do you? Diffuse corneal edema? Yeah. Comment on the cell count, by the way. I mean, this.
Sir, the cell count in this for the right eye is actually 629.6, which is actually very less.
Yeah, but isn't there something called how you need only 3 cells to count this, is it?
No, sir. This specular could not be reliable because
Correct.
the
So then
number
how
of
can
cells
you
counts is actually less.
Absolutely. So straight away you should discard this.
Oh.
You cannot even start to comment on this based on 3 cells. Okay. And then, so I would just straight away throw this specular, this part of it. And I'm surprised that there is a corneal thickness measurement of 584. Normally above what, when you get epithelial edema, what is usually the corneal thickness?
So more than 550.
More than 550, yeah? What's the normal corneal thickness?
500 to 520.
520 and 30 microns more and you'll start getting corneal edema, huh?
More than 600.
Definitely more than 600. 5, you don't get epithelial edema like this. I mean, you don't get epithelial edema for a corneal thickness like this. Okay. And the other eye is edema. I mean, what is the other eye? This
is the left eye specular. Here the cell density is 2320.
Hey, look at that.
Number of cells at this is 54.
Yeah. So look at the cell density here. So on what basis did you look at the corneal thickness? 478. On what basis did you call this one stage 1?
Stage 1 only gut test.
Yeah, it's only gut there. I mean, that see, like gut is so common in the population here. I would be very surprised. I wouldn't even really call this, and with a corneal thickness of 0.4. I'm sort of, I don't know the exact numbers, so I have to confess. But 478 to me is a thin cornea. It's lesser than average diameter, I mean, thickness. And with a cell density of 232, I wouldn't call it.
Since we're discussing about that
auto capture mechanism. This picture was captured by auto capture mechanism. Actually, each cell should have been counted specifically. There is a manual technique for counting.
Yeah, exactly. If you have, but I think the problem is, these I don't disbelieve the cell density, because the cell density where you can count is quite high actually. If you look at the top left, it's a very nice cell density there.
Only a morphological analysis would be reliable.
Yeah, even morphology is pretty good. It's just that there are these fuchs in between.
Yes,
and that is the only thing that is really there. And one of the reasons why you don't even see the cells when there is so much fuchses, because the fuchs endothelial cells are on a different plane. They are not in this plane. So that is the other problem. So, I would be very surprised if this diagnosis, I would still bet on viral keratitis, especially looking at the other eye.
Dr. Cyril, what is Hassan-Henle bodies?
Hassan-Henle bodies are actually existences of Western membrane, but it is seen in the normal population.
Where will those be present?
It's a degenerative change.
Yeah.
So Hassan-Henle bodies, it's because of aging and it is normal.
Yes.
Yes, you're right. And it's very difficult to make out the difference between fuchs. I mean, very difficult to make out the, these sort of islands, they are all Hassan-Henle till the fuchs diagnosis is made actually. So that's the thing, So I would be, anyway. Then now what do you plan to do for this right eye now, for this patient?
So right eye, we can, she has got a NS3 grade cataract.
Okay.
And her visual acuity is 6/36. So
okay.
We can actually plan for a cataract surgery and later on a DSEC, endothelial keratoplasty.
So did you give her, did you try?
Or a combined.
Combined. So did you see her follow up at all? After you gave these, you must have given some saline drops or something in the beginning.
Yes, sir. We had given her hypertonic saline drops. And
then how did she do?
Sir, left eye, there was no edema during her presentation, and it is still, there is not much of edema or any progression of the disease.
In the left eye, I'm talking about the right eye.
So right eye, we had actually, she underwent endothelial keratoplasty.
Endothelial keratoplasty, okay.
So when do you decide about endothelial keratoplasty? What would be your criteria to decide about endothelial keratoplasty?
So when the specular is actually, specular cell density is less than 800 and the corneal thickness is more than 640 microns.
Here it's not reliable. No, here it's not reliable. No. So what criteria will you decide? What criteria will you take to decide for an endothelial keratoplasty? If specular cell density is not available, what else would be the other criteria?
Increasing.
There is no inflammation. Cornea definitely has an edema. Patient has a decreased vision and an early morning blurring, which indicates that cornea is endothelium is decompensating. So these, if a specular is not available, based on these criteria, and also as Sir has told, patient didn't have a response to hypertonic saline. If patient is comfortable with hypertonic saline, we can continue the patient on hypertonic saline if patient is comfortable. Otherwise, since the edema is not resolving, there is patient is having decreased vision. There is an associated cataract, which indicates that the cornea is already decompensated. So in those cases, you can go ahead with a endothelial keratoplasty plus cataract.
So other than endothelial keratoplasty, what are the other options?
Sir, if the disease has progressed and there is scarring, then we can have a penetrating keratoplasty.
Okay.
Then other options are anterior stromal puncture.
Anterior stromal puncture for what?
For bulla scarring.
For what?
What will happen?
Bulla.
Oh,
What
you
will
want
happen
to?
to
Please, you okay? You want to sort of that will
Then
be.
you want to induce scarring when there is no scarring?
No, she has a bulla. So if it is progressing and there are more like.
So you want to induce scarring and then do cataract surgery so that you can give more glare and more halos and all kind of excess problems.
No.
I think we should move on and ask the other postgraduate also, because
most of the patients with bullae, and if they're not, as of now, the cataract is not very dense and the bullae burst and they have severe pain, you can also add a BCL along with other medication to relieve the pain as a temporary base. BCL also can be given.
to the cornea experts, may I just ask a small doubt? Do you do this endothelial function tests like, contact lens induced stress test or something like that to find out the function of the endothelium? Do you do it nowadays?
No, sir. Here in this case, the cornea is already decompensated because
in this
it's
case,
a localized corneal edema.
No, in cases in which you have a doubt of the endothelial function, you're going to do a cataract surgery. You don't know whether the endothelium will hold or not.
Another
because
guideline,
not everybody has a specula.
Another guideline which they give is that if there is an early morning blurring of vision, that indicates that cornea is gradually decompensating. The endothelial function is coming down. So along with that, other specular criteria are there. If the count is less than 1,000, if pachymetry, if it is more than 640, coefficient of variation, if it is more than 40.4, all these are indications where a cornea can decompensate following a cataract surgery alone. So in those cases, if these criteria are not met, then you have to proceed with the combined surgery. Rather, if there is a good endothelial cell count, corneal thickness is okay, there is no early morning blurring of vision, you can proceed with cataract alone.
If in case you're planning for a cataract surgery, what else do you keep in mind? Any postgraduate or Dr. Serin can answer? Any other postgraduate wants to answer?
Cataract surgery, soft shell technique.
Want to do soft shell technique. Okay, so how is soft shell technique done?
We use both dispersive as well as a cohesive agent. The dispersive is used to coat the endothelium and the cohesive to flatten the anterior capsule and to maintain an AC. So as to prevent endothelial cell loss or protect the endothelium.
So first what you put in AC?
Dispersive.
And then where do you put cohesive?
Under the dispersive.
Yeah, you have to put it in the center, posterior to the dispersive, because you want to lift the dispersive above. Once the dispersive is getting lifted up, then it goes the endothelium. So what is ultimate soft shell or ultra soft shell?
There we use we use BSS also. First the dispersive, which coats the endothelium. Under that, we have the cohesive agent, and beneath that, we have the balanced salt solution.
Okay. Yeah, we use BSS and a viscoadaptive OVD. So in case you're planning for a cataract surgery, you can do a soft shell technique also to support the endothelium, so that you don't want to create more endothelial loss.
One more thing, what is DSO? Descemet stripping only when it's done.
Sir, descemetodexis, that is done when we have only central, when gutta is localized to the center part of the cornea, and it is done 4 millimeter in size. The radius is actually 4 millimeter, and descemet membrane is stripped away without a graft.
Can you do anything along with that? Yeah, anything else along with that will you do?
No, sir.
If you can put, I forget the name of that compound, which factor, sorry?
Rock kinase inhibitors.
Rock kinase, yes, you can do the rock kinase inhibitors. Do you know what rock kinase do? Rock kinase inhibitors
They
do
help
in this
migration of the endothelial cells.
Migration of endothelial. Actually, it's not migration. I thought it was, it increases the stemness and possibly aids in multiplication of the peripheral cells that are there so that it can move in. I think that's what I thought it does, isn't it?
Yes.
Rock kinase, yeah, I think that's what it does. Yeah.
Dr. Serin, in case you're planning a cataract surgery, desect patient or post desect, what happens to the refractive error? So how is the IOL calculation? What you have to keep in mind?
Post desect, there will be a hyperopic shift.
Okay, yeah. Post desect, there will be a hyperopic shift. Okay.
So even if we have a minus during cataract surgery, it is still okay.
What is the advantage of having desect and a penetrating keratoplasty?
Madam, with desect, one penetrating keratoplasty has a longer wound healing, and the process is long. It approximately takes 1 year. And
yeah, it's a long rehabilitation.
Rehabilitation. Whereas in endothelial keratoplasty, there is no, there are less number of sutures or no suture, which actually helps in less astigmatism. The graft rejection percentage is actually less, and better
suture-related complications are not there. Suture-related issues and the faster recovery.
Still rehabilitation, yeah.
Since your specular photo is still on the screen, where do you have a reversal of pattern?
IC syndrome, Chandler's disease, Chandler's syndrome.
So how does it look? How does a specular microscopy of reversal pattern look?
There will be light center with dark borders.
That is a normal one.
That is normal, no? That is normal.
Dark center with the light borders.
Dark center. See, normal specular microscopy, you have the hexagonal shape, the bright in the center and dark borders. Reverse means it is darker in the center and white borders. So rounding of the cell borders, and when you have dark and white reversal, then you have, it's called as a reversal pattern in specular microscopy. So that is seen in ICS. Where all you see pseudogut case in general?
Madam, in traumatic cases, inflammatory conditions,
traumatic,
Infectious.
inflammation, infection, uveitis,
Uveitis.
all you have pseudogut.
And how is it differentiated from a true gut tape?
Sir, pseudogut, once the inflicting condition is reversed, the pseudogut, it resolves.
Resolve. The transient phenomenon.
Thanks.
And what are the different types of endothelial keratoplasty? Can you name the different types of endothelial?
Sir, basic descendant membrane endothelial keratoplasty, descendant membrane automated endothelial keratoplasty, descendant membrane keratoplasty. Basic is descendant stripping endothelial keratoplasty, and DSO or desmetorexis without endothelial keratoplasty.
And PDAC, what is the?
Desmetorexis without endothelial keratoplasty.
In general, males or females, who do present more with tubes?
It's more in the
Tubes are
female
common.
population.
Yeah, we don't know the exact reason, but it's generally seen in female population more than males.
Why did you ask for a family history?
Sir, tubes has an autosomal dominant inheritance pattern.
Okay.
So,
okay. How many siblings does this patient have?
2.
Huh?
2, sir.
Why do you ask that? Why do you want to know the number?
Because to know the family tree.
Know the family tree. Why do you want the sibling, number of siblings? You need to ask.
Autosomal dominant pattern. And
so what happens in autosomal
whether there's
dominant?
a transmission to the.
So how will the number of siblings matter? Let's say the patient has 1 sibling or gives you a history of 3 siblings.
So 50%.
Yeah. So if you have only 1, there is 50%. You're unlikely to find it in a sibling. But if you have 3 other siblings and none of them have it, then you can be more sure that this is not autosomal dominant. By playing chance, you realize that some of them should have had it if it is a inherited autosomal dominant type of a thing. Again, when you really need specular microscope, that's a problem with specular microscope. When you have corneal edema, you don't get specular microscopy well. Very few specular microscopies work when there is actual corneal edema, which is when you really want to make a diagnosis.
Very true, sir. Very true.
That's the problem with specular microscope. So quite often you need to rely on your clinical skills rather than the specular microscope to make a diagnosis.
In this patient, the patient has cataract, nuclear sclerosis, but in case the patient is pseudophakic, then your diagnosis to right eye can be probably a PBK. Pseudophakic bullous keratopathy. It has all the features of bulle, corneal edema, and all the signs what you're describing. In case the patient had undergone cataract surgery, then your first diagnosis will be PBK.
Sir, in one more thing, if, as sir told, this can be a case of viral endothelitis also. So what investigation will you do to confirm your diagnosis?
Sir, diagnosis of viral.
If there is active viral endothelitis.
Diagnosis of viral endothelial keratitis, viral keratitis.
PCR for viral DNA.
PCR we can do.
Yeah, for HSP you can do.
PCR of what? What can you do of PCR of what?
Tear fluid.
Tear fluid may not be the best. You may not get much from the tear. You may even have to do a parasitosis.
You can do an aqueous tap.
Yeah.
And you can send the sample for PCR.
Yeah, that would be best.
Another option is that if the patient is not, if cornea is not decompensated, you can give a trial of steroids and antiviral also if patient is not affordable. That is off the book.
No, I think you should. I would have given in this patient trial of steroids and antiviral, because it may be a borderline and this may have just tilted the balance. This endothelitis may have tilted the balance. Okay, I think there are no other questions. Maybe we should hand you back to Dr. Gopal.
It was a very good in practice section, and Dr. Thomas Kuriakos was extensively and dynamically involved in multiple questions. I hope all the PGs are truly benefited by this 1 hour section. So especially all the exam-oriented questions and the discussion, the answers, everything was discussed. So it should truly benefit you guys.
Thank you very much. Thank you very much for the discussion. Thank you, Dr. Hilda, as well. Thank you, Thomas, sir. Thank you, Dr. David. And thank you, Dr. Risha, for organizing it and making it happen. And it will be in YouTube and everyone can go back and listen to it, especially for the exams. And the next week, we would be having a discussion on investigation, which would be optical coherence tomogram. And I would also like to thank Dr. Sarin, who braved to present. Thanks a lot.
Thank you very much.
Thank you, everyone.
Thank you very much.
Good night.